Everyone, and thank you for being here for this session. Today, we're going to be going through how to stage a patient in ARIA. And I'm going to just start on this screen with a test patient. So again, when you joined the center, you'd have received your login details to be able to access the EMR. And you would have had a preliminary orientation session of how to use the EMR. But these videos are going to just go into a little bit more detail of how to stage tumors. So we're going to start with creating an appointment here. So I'm using today's date, 27th of July, and I can just click on today, or I can select the date I want. And then I'm going to select the type of appointment this is. So is this a first consultation, a follow-up, weekly radiotherapy review, or other type of appointment? So I'm going to do first consultation here. And then these are all the EMR items that you go through. When you complete an item, so let me just take the journal and use this as an example. If I click here, and I'm just going to type some jargon here, and I approve it, it will automatically check that column to show that that encounter item has been completed. So at the end of the encounter, if this is all I completed today and I close the encounter, it will show that all the other items were not checked. Now, how to combat this? So if you're seeing a patient for a follow-up appointment, for example, you may not need to do review of systems again at this appointment, and you certainly won't be doing chief complaints at a follow-up appointment. So what you do in that regard is you select not applicable. So it shows that this column is not applicable on this specific appointment date. But if I'm filling it today, I come and check this to show that it has been completed. So those are these two columns. This column is to show that the item has been completed. This other column is to show that the item is not applicable at this appointment. Back to what we were talking about today, we're talking about diagnosis. And I'm going to just start and create a new diagnosis for this patient. And I'm going to use the most common and the most complicated one, which is breast. So when you open this diagnosis workspace, it looks like this, and I'm going to just enlarge it a little bit. Starting with the date, ideally, if you don't do anything, it's going to leave it as today's date. But what that then does is that if you want to really check patients who were diagnosed with breast cancer between January and October 2023, you won't have accurate dates because this is not the date she was diagnosed. This is just the date you are seeing the patient. The date she was diagnosed is the date that is on her pathology report or the biopsy report or whatever diagnostic means you're using. So if your diagnosis is from imaging, it should be the date on the imaging report. If it is from biopsy, it should be the date on the biopsy report. If it's from pathology, it should be the date on the pathology report. So I'm going to, again, use an assumed date here. So let's try and put it to 2022. So if you click on here, it will pull out and, group the date into larger dates. So we've come to 2020 to 2029. I'll select 2022, choose a month, and pick a date. So that is the date on this woman's fictional biopsy report. The next thing is the code. So every cancer has a code. You can search with the code or you can search with a keyword. So if I know the code, for example, I can say prostate is C61. It will come up with prostate. But again, there are millions of different codes out there. So you might not know all the codes in your head. You don't have to. What you will then do is search with a keyword. Now, if I come to the keyword and I type breast, I'm going to have lots of different things come out because it's going to show me both malignant and benign conditions of the breast. To narrow this search down, I will click on cancer codes only right over here. And what it will do is that it will pull out all the benign ones and then show me just the ones that are related to malignancies. And I'm looking for the specific one. So this woman has a malignant neoplasm in the upper outer quadrant of the breast. And I choose this and I click OK. And then it codes it for me. So the code is C50.4 and we're using ICD-10 here. And this is the code description, malignant neoplasm of the upper outer quadrant of the breast. Now, the clinical description is your own personal description. It's how one clinician would describe something to another clinician when having a conversation. So it will automatically put in the description, but it's always best for you to now add your own to say, let's say left breast triple negative cancer, triple negative ectopic capsule vaccine, triple negative locally advanced cancer, right? And then I can add upper outer quadrant if I want to that. So the clinical description is really just what you would, if you are writing in, the physical case files, how would you write this? And if you were having a conversation with a colleague, how would you explain it? You're not likely to be saying malignant neoplasm of upper outer. You're going to say left breast CA, triple negative, upper outer quadrant, and that's what you should write in your clinical description. Now, if you want to add any more details, you can add details. So you can say things like skin dimpling at presentation, like that, or whatever else detail that you want to add, you can add that. The status is asking you what is the status of disease that you are diagnosing here. Controlled means that you have treated it and it is under control. Active means there's active disease going on here. Cured means you are saying that you have cured this patient. Remission means she has had treatment, there's no evidence of disease at this time, this patient is in remission. It's important to select the right status in this diagnostic part, because again, it all comes down to being able to extract data for all of our uses. If we don't properly put the correct status, you will get the wrong information when you can pull out the data. So again, we're going to put active here because this is still active disease that is going on. And the status date is today. So I'm saying that as at today, this is still active disease. The ranking is primary, meaning that this is the primary diagnosis. And I will explain that when we talk about malignant. So the method description, so the diagnostic method is how diagnosis has been made. If it was made on core needle biopsy, fine needle aspiration, then you're going to select biopsy for diagnostic method. If it was diagnosed on imaging or say CT scan, you select CT scan. If it was a breast MRI, you select breast MRI. If it is post-mastectomy and you have a histology or pathology, a pathology report, you select histology pathology. So this is just saying how was the diagnosis made, and you select that. And if you want to describe it more, we've said biopsy up here. Now we can say it was a core needle, or we can say it was a fine needle aspiration. So you can describe the method there. Now, on this other side of the screen over here, most of the things again are automatically filled in. So breast, disease category is breast, disease size is breast. It has put the version of the ICD and put the description. And it has put the behavior saying that this is malignant. Laterality is something that is very important. And when we forget to fill it, again, it gives us useless data. So you have a bunch of breast cancers, but you can't even tell how many right breast cancers versus left breast cancers you have once you don't select laterality. So for some condition like prostate, you will be selecting not applicable because prostate is central. If it is bilateral, then you pick both sides. In this situation now, we've said that this is a left breast CA, so we have to put left breast CA here. And this is all you're going to fill on this column for a primary tumor. If the patient has metastasis, then we're going to fill in the rest, but I will come to that when I discuss metastasis. So that's diagnosis. And that's definition. Now going to pathology, again, you click on this first column here and you select the type. So again, I'm going to use the most common thing. So this woman has a ductal carcinoma, and I'm going to say the type of ductal carcinoma. It is most commonly, it is usually duct carcinoma, not otherwise specified, that I put there. And then the grade. So we'll have the grade from the pathology biopsy report. Is it a grade 2? Is it a grade 3? If it is not stated, then we have to pick grade X, not determined or stated or applicable. Once you leave this place blank, then it is possible it is a grade 2, but you just forgot to fill it in. Or it is a grade 4 and the person just forgot to fill it in. So it's important to say that it's not stated if it was not stated. Tumor size assessment will not be relevant on biopsy. If the patient if this is a post-mastectomy report we're looking at, then we should ideally put what it is. And you usually, again, it will be gross. And you can see the largest focus was 5 centimeters. Is it multifocal? Yes or no? It is no. It's a solitary tumor. What about the margin status? Did they tell us that it's negative? Did they tell us that it is positive? Did they say it is focally positive or positive in multiple spots? Or they just said positive and they didn't tell us exactly what? So in that case, it will be positive, not otherwise specified. Or is it unknown? The margin status was not reported, so we don't know, and then it is unknown. Is this tumor an invasive tumor? Yes, it is. And what kind of invasion? There is perineural invasion. Yes. Is it focal? Is it extensive? Is it just present? They just said there's perineural invasion positive, and they didn't tell us more than that. You select present, not otherwise specified. Is there lymphovascular invasion? Did they say there is no lymphovascular invasion, which is not present? Did the report say it is present, but didn't say more than that? Did the report say there is focal lymphovascular extension, extensive lymphovascular extension, or was LVSI not mentioned at all? Dermal lymphatic invasion not mentioned at all. Dermal invasion not mentioned at all. So again, we need to be as detailed as possible in filling this in. In the margin status, I forgot to talk about the location. So we've said margin status is unknown. That's why I didn't put in the location. But let's say I was saying the margin status is positive, not otherwise specified. Now you can select location if you have that information. And what I want to point out up here is that you can create templates. So I can say something like, I can just add some little more detail to say, margin is less than, let's say less than 1 cm from outer margin. And when I put this here, I can say add to comment list. If I click on this, add to comment list, and I give it short description, and I say 1 cm margin, and I save it. What it means is that the next time I'm filling in information about margins, I can just click on here and it will show me all the available comments. So it's like a way of speeding up your work because you're saving a template for a comment that you use quite often. And there are multiple places in ARIA where you'll find that sort of usage. So going forward, again, you can talk about DCIS and the same options. Is it minimal, moderate, extensive? Has the report just said DCIS present and not otherwise specified? Is DCIS specifically absent, or was DCIS not mentioned? So we can say it was not mentioned, and that is that. Are there microcalcifications? Not mentioned. Necrosis associated with DCIS? Not mentioned. When we get to the nodes, we're assessing the nodes. This is again only possible with a post-mastectomy or maybe a wide local excision, but they've done an axillary sampling dissection. How many nodes were removed? Number of nodes removed in total. So 11 lymph nodes were taken out in total. How many were positive? 5 nodes were positive. Cytokeratin positive only. If it's not mentioned, you leave that place blank. What was the size of the largest positive node? The largest positive node was 2 centimeters. Was there extracapsular extension in the nodes? Yes or no? If it is no, it's not present. If it was not mentioned, it is not mentioned. If it was present and not otherwise specified, this is what you select. If it is focal, extensive, you select that. Now going to, or if the node involvement was not investigated, you just click on this and it's automatically blanks that out, but it lets us know that the node involvement was not investigated. If you don't select this and you don't fill in all this, the assumption is that the nodes were investigated, but you just haven't reported it. And there's no way to be sure when that data is pulled out. There's no way to be sure that this patient didn't have nodes or had nodes or whatever. So we have to always indicate, even when it is negative, that negative indication has to be specified. For receptor status, again, it is the same options. Estrogen negative, estrogen receptor positive, or unknown. If it is left blank, then that means that it is possible that this woman is AR positive, but the doctor just didn't fill in the information. And that's why it's important to specify that it is not known or it was not done. This is usually not done, and if it's not done, you just leave it blank as a percentage. KI67 status, if it's not done, you leave it, put it as unknown. HER2 status, again, you come and say if it was 1, 2, 1 plus 2 plus 3 pluses, if it's unknown or if it's not tested. If you're saying it is 2 or 3 pluses, you need to specify how. Was it on IHC? Was it on FISH? Or do you not know? The report just said this woman is HER2 positive and you don't know how they did that. So you can say that the method is unknown and the status is unknown, or the status is, if it is HER2 positive, then obviously it must be 3 pluses. So you specify whether she's positive or not, and you specify if it is if you know the method that was done. Just to go over that again, for HER2 status, immunohistochemistry has been done for these patients, and they said she's positive. If they say she's HER2 positive, then we know that it is 3 pluses. If we have more information to say it is equivocal or negative, negative means that it is 0, is not amplified. If it is equivocal, then it is 2 pluses. So that answers all those questions. If we don't know and it was not tested, then we say it was not tested. So you specify all of that. Oncotype DX, recurrence score. If there's a recurrence score, this is where you record it. And then you'll be able to say the recurrence risk. If Oncotype DX is not done, you select unknown. And then you can make any other comments on the pathology that you want to make that have not been covered in all the things that we have gone through. But this is just to show how detailed ARIA is and how much information we can get from ARIA. But if we don't fill in all these columns, they will just stay blank. And then the question is, was there DCIS, but the doctor just didn't fill it in? Or is it that DCIS was actually not mentioned in the report? And then now to staging, which is the main thing that we wanted to do today. We're going to stage this patient, and I'm going to start from the top. So starting with basis of staging. As we all know, staging can be clinical, it can be pathologic, it can be recurrence. About custom when we get to the end of this session. So if we're staging her clinically based on imaging and physical examination, it is clinical. If it is based on mastectomy report, surgical report, then it's pathologic. So in this situation, we're going to say clinical because we're staging on clinical basis. And we're going to put the date stage. So what date did you stage this patient, which is today? And then is this the current working stage? I can select yes or no. If you have only one stage, it would have to be the working stage. Now, if I stage this patient today, I take chemotherapy, and then she's downstage, and I want to stage her again post chemotherapy, I can now select working stage on that new stage, and I will take it off this one, because the new stage is now the working stage, and this is the old inactive stage. So again, on the second line, disease site is breast. The staging scheme you are using, AJCC 8th edition is the most current edition. But if you wanted to use a different one, you could select that here. If you wanted to use 7th edition, you could select it. If you wanted to use 5th, you could select it. But 8th edition, incorporates all of the HER2 positive status and co. If, for example, you didn't have all the information you needed, you might want to use a 7th edition staging, or you might want to use custom, but we'll talk about it in a little bit. And then this column is going to automatically complete itself when you fill in all the parameters. And the stage timing is what we're doing here. So is this pre-chemotherapy, post-chemotherapy, pre-surgery, post-surgery, pre-radiation? Most of the patients we see for breast are coming for post-mastectomy radiation. So you can say that this is post-surgery, or you can say that it is pre-radiation therapy. But I'm going to choose, let's see, this is a new first appointment. I'm going to select pre-chemotherapy, so excuse me. So now the staging criteria. For the T status, because we've selected clinical, it's showing you the primary tumor. If I toggled this to pathologic, you would see, sorry, if I toggle, so we're on clinical. So if you go to T stage, you have all the T stage options up here. And then I'm going to select T4. I wanted to show something. Give me 1 second. If I go to post-surgery, and I click pathologic, ideally it should be pathologic criteria, but it's not. Okay. So as we were saying, this patient has come with a tumor that is greater than 2 centimeters, but less than 5, a tumor that's greater than 5 centimeters, or tumor that has an extension to the chest wall or skin or whatever. So we select whatever T stage we believe it is. Then we go to the nodes. So if you look up here, this is pathological node staging, meaning that this is based on findings at surgery. So you need to close that and come to based on findings at clinical examination. So we're going to say that she is a stage N2B, N3, no, let's pick an N3. So she has ipsilateral level 3 axillary lymph nodes. She has internal mammary lymph nodes, or she has metastasis in supraclavicular lymph nodes. So the question someone asked me was, how will you see infraclavicular internal mammary lymph node, infraclavicular or internal mammary? And that will usually come up on a PET CT, is where you will usually find it. You will not be able to tell that there's internal mammary lymph node involvement on just physical examination. So metastasis, based on imaging of this woman, there is no evidence of distant metastasis. So we're going to select an MO at this time. And then the grade, we are saying she's a grade 2, HER2, she's HER2 positive, or she's HER2 equivocal, we don't know. She's ER positive, she's PR positive, or she's PR negative, ER negative. And then the oncotype DX is usually what, so many people stage and stop here because we don't have oncotype DX. And then the stage is going to continue to show as the stage X. So if you have it, select it. If you don't have it, go to score not evaluated. Now, I selected HER2 equivocal because I wanted to show what happens once you don't complete every aspect of 8th edition staging. The system is not going to be able to stage the patient for you. If I change this to HER2 positive, it's going to stage it to 3B instantly. If I selected HER2 negative, 3C. But if I go to equivocal, it goes back to a stage X. So the point I'm trying to make is that once you see a stage X, it is because you have not completed every aspect of the staging. So again, this is showing a 3B. If I went to oncotype DX and I removed it, it will go back to a stage X. So once you don't stage every aspect of, once you don't fill in every aspect of the staging, it will show you a stage X. And what do you do in that situation? Let's assume this patient is an HER2 equivocal. And we're seeing a stage X, and we don't have it. We simply don't know. We don't have fish yet, and we cannot confirm yet what her HER2 status is. We have two options here. You can use an older staging method and click and clarify that you use a 7th edition, which is not, I don't think is the ideal, because it doesn't even show you what the parameters are. You basically have to do it from your head. Or you can stick with 8th edition and change to custom. Now, the custom means that you decided to use anatomic staging. And what that does is that you will still fill in all the parameters. So we're still going to fill in a T3, still going to fill in a clinical N3, we said. We're still going to fill in an MO, grade 2, HER2 equivocal, ER negative, PR negative, oncotype score not evaluated. And then based on all this, because we've used anatomical staging for this patient, we will stage her as a 3C, for example, or just as a stage 3B. Stage 3B, yes. So we have done custom staging because we don't have all the information that we need to be able to fill this part in. And the important thing is that when she does confirm the HER2 status, is to come back up here and do a new staging, rework the staging. And like I said, you would uncheck this, and then that new staging, updated staging will become the working stage, and this will no longer be the working stage. So I'm going to approve that. So this is this patient now, and we're going to save this, and this is her diagnosis. I will select OK. Now, let's say she comes back sometime after we've done this appointment and unfortunately has metastasis. Now she has metastatic disease to the brain, the lungs, and the spine. We now have to update our methods, our diagnosis, and all of that. The first thing I'm going to do is I'm not going to edit this old stage because this is what she was at presentation. If I edit it and change it, I'm basically erasing her history. And that's not what we want to do. We want to be able to see how she progressed through time or through the treatment course. So I have to start again and say she's got breast cancer. All right. And we remember that it was upper outer quadrant of the breast. And now my clinical description is going to be metastatic left triple negative breast cancer. Because again, let's say we confirmed it and she was HER2 negative. So metastatic triple negative breast cancer, diagnosis date will be the date that is on that report, which we're using now to say she's diagnostic, she's metastatic. So, and how did we confirm the metastasis? We would say that it was done on imaging. So MRI, let's say it was PET-CT and PET-CT is not here. You can select other and then come here and say PET-CT. Was confirmed on PET-CT. The status date is today. So as of today, this woman is metastatic on PET-CT actively. And what is the ranking of this disease? It is still primary, right? And then it is still breast. And we still need to confirm the laterality, which is the left side. And then we'll fill in all the pathology and pool, and we can come in here and fill in the stage. So I'm just going to skip through this very quickly because I want to get to the point. So she's a T3, N3. She's now an M1, still a grade 2. A2 is now negative, ER is negative, PR is negative, oncotype score is not evaluated. So now it has staged her for me as a stage 4. And this stage timing now is post-chemotherapy because she had chemotherapy before. And this is, again, based on clinical findings, not on pathology findings. And I'm going to approve this stage. What I'm now going to do is go to this old one. Yes, I'm saving my changes. I'm going to go to this old one that we did before and edit it to show that this is no longer the working stage. I have a new stage available, so why is it? Okay, let me save this first. So come back here, edit this. I'm saying it's the only stage available. That's enough. Why doesn't it come out? Okay, I'll come back to that. I don't know why it's not coming out. But what I wanted to show here with the metastatic left breast CA, so let's edit this, is that I want to show how to connect a metastatic lesion to the primary lesion. So this is the breast lesion now. We are going to add brain. So she has metastasis to the brain. So again, diagnostic date is today. And we're going to add the code for brain. So this is brain. We're looking for cancer codes only. If you just have brain, you're going to see a lot of different codes. But we're going to let cancer codes only. And we're looking for secondary malignant neoplasm of the brain. Because this is metastasis, it's not a primary. And that is the code there. And now I'm going to put my clinical description and say that this is brain mets, secondary to left breast C. And then I can add details to say she has multiple lesions. Largest is 4 cm. And I can say maybe both hemispheres or just whatever detail I want to add. This status is active. As of today, she has brain mets. Diagnostic method is on imaging. So like I said, it was PET-CT for the other one. But here, let's say we want to say it's an MRI. So I can say it was brain MRI. Is how we diagnosed it. Now the primary here, ranking is going to be second. This is the second malignancy, so to speak, that she's being diagnosed with. I'm coming to this other side. All this information is there. So the ICD version, the disease site, the malignant, the laterality is not available because it is the brain. It's not applicable because it is the brain. And then here, select the primary diagnosis. So I'm attaching this here because we already had diagnosis, 2 diagnoses in the system before. But if you don't enter this, you can't attach it to anything. So this is now, she has metastatic liver breast. I'm going to select OK. And I'm attaching it to that breast cancer. And here, the primary site is the breast. Is this a distant metastasis? Yes, it is. Is this a recurrence? Let's say, no, it's not. This is progression of disease as opposed to recurrence. And so I've put all that information there, and I'm going to select OK. Again, if you have the pathologic information, let's say she's done a biopsy of that brain lesion and you want to fill in the pathology, you can fill all of that in here. Staging here is not really going to be applicable because this patient is metastatic, like we said. We know that it's stage 4. And then also for brain tumors, it's really more about grading, so it's not going to be relevant here. So we've put in all the information about the brain mets and we select OK. So this brain mets now is linked to the breast cancer. And if we don't put that information, if we don't link them together, when we want to pull out our data to see how many patients have brain metastasis from breast cancer, or brain metastasis from prostate cancer, or brain metastasis from lung cancer, once you have not linked it in the diagnosis, you will not be able to pull that information out. You will see brain mets if they have been entered, but you will not be able to specify which ones are secondary to what primary disease. Now I'm going to add, let's add, should we add lungs or bone? Let's add lungs. So lungs, I'm skipping a couple of steps here that we've gone over. So if you know the code, you enter the code. If you don't know the code, you use the keyword, which is what most people will use. You enter lung. You remember to toggle cancer codes only if I'm going to show you a whole bunch of things. Remember that you're looking for secondary malignant neoplasm, which is here, C78, and you select OK. So you put your clinical description, which is what, lung mets or pulmonary mets from breast cancer. If you want to add details, you can add details. You can say multiple lesions, both lungs, whatever detail you want to add. Status is active. Diagnostic method is, again, on imaging. If she had a biopsy of the lung, you can add biopsy. Whatever the diagnostic method was, you add it. What I want to show over here is that when you come to this other side, laterality, if she has just a lesion in the left lung, you can select, or right lung, you can select, or both lungs, you should include lateral because the lungs are paired. So it's important to fill in laterality for this one. And then again, attach it to the primary diagnosis, which is the left breast cancer. And then the primary site is the breast, as we've said. Distant metastasis, yes. Is this a recurrence? No. And select OK. So I hope that with that, we understand the basics of how to enter diagnosis and how to stage a patient in ARIA. There'll be more sessions talking about all the other things. Now, because today I'm not doing all of this for these patients, I'm going to click on this column and I'll mark all the encounter items as not applicable. So it's just the encounter items I have done today that will be checked as completed, and all the rest are going to be not applicable today, and I'm going to save this encounter as complete. Thank you everyone for joining. If you have any questions, please meet with your point person. A point person has been appointed for the residents and medical officers. Meet with the point person to answer any questions that you have from this session. Thank you.